Okay.
Yes.
So I will continue the tomorrow yesterday talk. So the classification is not finalized. So there
Mm.
is unclassified, some types of unclassified fracture is still exist. For example, this one, the complete fracture, but abducted, adducted. As you know, such kind of fracture is sometimes very traumatic. It can cause some complication, such as dislocation and osteonecrosis of the femoral head. So how about this one? To the total compression type. So it is also difficult to manage because the very lack of the volume of the femoral head. It's the no space to insert the screw, especially over the screw head. And how about this one? Oh, this one is still got in stage 2, non-displaced, but in the lateral view, its head is flexed posteriorly. So it is still difficult. So what is the limit of the posterior bending? And it is, do we need to reduce this posterior flexion or not to fix in situ? It is still controversial. So, because this is the reliability or reproducibility of the guarding classification. So if we classify the fractional neck fracture into the 4 classification, the kappa, it is a little, it is the reproducibility of this value. It should be the 0.3 to 0.1. It is incredibly low. So this is reproducibility is less than half. So it means if we see the same X-ray by the 2 surgeons, one of 2 patient is different, have the different diagnosis. So classify to the different category. It is very interesting. More easily to if you classify into the 2 classes. The one is displaced, another is not displaced fracture. Even to a very simple classification, the kappa value is around half. So even using the CT scan, so if we use a CT scan, the relative intra-observer reproducibility come to the around half. It is also incredibly low. So the problem is there are so many types of unclassified cases, such as complete abduction fracture and total compression fracture, and posterior bending fracture. In addition, what is the limit to the fixation for the fixation? So in the previously, we made some group to discuss the femoral fracture using the dual screw, and then we proposed the new classification system. It is not so difficult to understand. So we classified into this insufficient fracture, subcapital fracture, and a transcervical fracture. It is a true femoral neck fracture and a vertical sharing fracture. So difficulty is still in the subcapital fracture. It is very difficult to classify. Other type of fracture we can easily classify. A subcapital fracture we classified as non-displaced fracture, including the insufficient fracture, the intermediate fracture, and displaced fracture. Non-displaced fracture is like this. we can see the fracture line, but no displacement. The intermediate, includes the abduction fracture, but there are two types of abduction fracture. So one type is, this is abducted fracture. The one is the incomplete fracture. It is a true Garden stage 1. Another type is a complete type. It is similar to, it looks like the Garden stage 1, but fracture is complete. So I don't know, we can deal the two types of fracture in the same fracture category or not. The second one, the intermediate fracture, is a very controversial. So the opinions are different among the surgeons. So one is extended fracture, with a posterior bending fracture. Can we accept it? Or if possible, if yes, then what is the limit? Or what is the angle of, or what is the degree of compression of the posterior side? Nobody knows. So furthermore, if you see this fracture, the fracture should be reduced or fixed in situ in this situation. So it is very controversial. So, and the one is totally impacted fracture. So it is in this fracture, the space for the screw is very small. It's quite difficult to insert a screw. And in addition, the whole vessel, the artery is damaged due to the impaction. Maybe it can easily cause osteonecrosis, even after the bone union. And the other one is displaced fracture. In the abduction fracture, it is something like the Garden stage 3. This is the totally displaced fracture is it is Garden stage 4. So what is the controversial? There are still some fracture type. It is unclassified. So such as abduction and impaction and complete fracture. And the posteriorly displaced fracture, posterior bending fracture, and the totally impacted fracture. They are still in controversial. And we need to standardize to take the radiography. There we can see the different view in the axial view or Rauenstein view. This is different. So ideally, axial view should be better. And if possible, 3D CT or MRI, sorry, this is the MRI. MRI are very useful, especially to diagnose non-displaced insufficient fracture. It is quite impossible to diagnose using the normal radiography or CT scan. Okay, so this is the DRS screw I devised. So this system is something like the mini CHS, like this. So there are two types of screw system. This is a thread barrel. It is a simple screw. It can to slide into the barrel. And another one is this one. This is the plate barrel. So it has a one whole side plate. It can provide us angular stability for the femoral head fracture. So it can slide. It means the fracture can the compression force. We can add the compression force between the fragment, and both dynamic and static. Dynamic means after the operation and during the weight bearing, this weight bearing force will act as a compression force between the fragment. And the starting compression means if we drive the screw, this one, then after to reach the longest length of this screw into the barrel, after that, the femoral head fragment will come to the distally, they can cause the compression force. And no screw migration. This cannot be separated due to the mechanical construction. So no protrusion. So there is some space for the sliding into the barrel. So this is a very, very useful to add a side plate. Of course, you can use the compression hip fracture for the femoral neck fracture, but CHS is very big. The diameter of screw and barrel of screw, diameter of the barrel is very big for fix the femoral neck fracture. So previously, this previous version of URAC is devised in 1992. So then come to Japan and renovated to the DSS. And then I divided the final version of this DRAC screw. I devised to modify, I made a modification from this old version to the newest version. This is the cannulated, and interestingly, I added the side plate at this version. So this is maybe the first device that have the side plate for the implant for femoral neck fracture. So this is a screw barrel. It acts as something like the Harvard screw due to some different pitch of this screw thread. So instead of the different pitch of the thread, so after the reach to the longest distance, longest length of this screw, then I drive the screw, then proximal fragment, then come back during the screw driving into the femoral head. And something like this is just like the DHS. But so this innovation is this plate has only one the hole for the screw, because multiple screw to the long plate is very difficult to fit to the lateral cortex of the femur, because this angle is decided, strictly decided. If there is some difference of the angle between this angle, the screw and the plate angle, and neck and shaft angle, some mismatch of the lateral cortex and the plate can occur. It is very serious problem. But to adjust this divergence to plate on the lateral cortex is very easy in the trochanteric fracture, because the bone around here is already broken. So we can easily change the angle, the bone around here. But in the femoral neck fracture, is bone around here is intact. So we cannot change the angle between this area and this area. So if once we make the screw improper angulation, the insert the screw, then plate comes like this. It cannot be adjusted because the bone here is intact and very hard. So to avoid this, I made some curve here to adjust to some angulation error to insert this screw. So this is a serious problem after the pinning of the screw. So rotational displacement and cheese cut of this area. So in addition, if the fracture is shortened due to the sliding of screw, of course it can act as a compressive force, so it is beneficial to bone fusion. But in the same time, so this shortening is too much. This screw end come to the subcutaneous region like this. So sometimes it can penetrate the skin and it can cause the diabetes and some pain and even infection around here. So this is also some problem of pinning because this length is decided. So in addition to secure the fixation for the vellus displacement, this pin must be stabilized by the 3-point fixation. The 1 point is femoral head. This fixation should be very stable to prevent the vellus displacement of this pin. This pin should be touched to the calca. We call it the calca buttress. It is necessary to prevent the vellus displacement. And the third one is here, lateral cortex. So using these 0.3 points, we can achieve the secure fixation for this femoral neck fracture using the simple pin or screw. But it is quite difficult to, So insert here because it is very 3-dimensional. So if we insert the screw a little bit posterior side, anterior side, then the screw cannot come here. To just the center of the femoral neck and just above the calca femoral, we can insert this one. So insert this pin just near the medial calca femoral is quite difficult. So instead of 3-point theory, 3-point fixation, if we add the side plate, so vellus stability, we can get the vellus stability easily. So as I said before, so use the CHS for the femoral neck fracture is very, very difficult. But if you use this type of side plate implants such like DHS or CHS, if you, even if we insert this screw in proper angulation, something like this is to vellus alignment, it can be reducted because this area of bone is already broken. So easily we can change the angulation. But it is quite difficult in the femoral neck fracture because the bone quality of this area is very, very strong. This area bone is very intact. So we cannot change the angulation and we cannot fit this plate to the surface of the lateral cortex. This is the difference of the trochanteric fracture and the femoral neck fracture. So it is very stabilized. So another advantage is it cannot penetrate this side. due to the screw and barrel mechanism. So this is quite easy to add the compression force to just drive the screw into this femoral head. After that, we can add very easily the compression force between the fragment, just like the two-piece Hubbard screw. So in addition to, if we use this side plate, the stress is separated too. Using this screw, the bone stress is concentrated around here. But if we use the one screw, the stress of this the loading force is separated to this area and this area. So I made this plate the surface of the round shape. Thanks to the round shape, we can accept some minor angular divergence to around plus minus 5 degrees. Plus minus 5 degrees is acceptable due to this round shape. This is the finite element analysis. Compare the Hanson pin and their axis screw. This is quite similar to the cannulated screw. This is the Hanson pin, and this is a dual axis screw. The red one is the stress is concentrated area. So the Hanson pin is stress is concentrated around the pin insertion area, like this here. But using the side plate, like this, it's not concentrated. Stress is not concentrated around the screw. And even in the proximal one, and the middle one, and the distal cortical screw. So this is the stress is very, very separated. So again, this is the Hanson pin. The two holes, the proximal hole and the distal hole, all stress is concentrated these holes. So in addition, the cross section of the device is smallest in DRSC. So the screw is only the 5 millimeter. Maybe it is enough to provide a good fixation and a stabilized fixation. The Hanson pin is the largest, and the DHS is still big diameter. And this one have the only one screw. So rotation on the femoral head cannot be prevented. So maybe this is the next should be the operation procedure. So to do the femoral neck fracture fixation, the marking is very important. So this is my technique. Before the operation, I put on the wire on the hip and see the fluoroscope and adjust this portion as the base screw portion, and then draw the line on the skin marker. Then next, draw the lateral edge of the cortex, similarly using the pin, and draw the two lines on the patient's skin around the hip. Then draw the line perpendicular to the lateral cortex line. Then the skin incision should be here, between the two lines, just like here, So normally for the dual AC screw, the skin incision should be the 2.5 to 3 centimeter, quite small. Then like this, draw the line here, and draw the line here. Then draw the skin incision. on the lateral face, like this, and then draw the perpendicular line. Then adjust the CR a little bit sloped, so to come to the femoral head center at the extent of the femoral shaft. So this view we call it a true lateral view. In this view, the femoral shaft line and the femoral head center is come to the same line. So in this view, the anteversion of the femoral head is completely adjusted. So in this view, I put on the metal bar, and then I can identify the femoral shaft, and then again draw the line like this. Then open the skin here and insert the screw from this screw. This is the very important to draw the line using a true lateral view. So this is the conventional lateral view. This is horizontal to the floor. But to the femoral head, it is the oblique view, because most femoral bone has an anteversion. But this, the degree of anteversion is different among the patients. So then, instead of rotate the femoral bone, they rotate the serum. So mathematically, between the horizontal to the vertical, we can find this view. In this view, the axis of the femoral shaft come to the center of the femoral head. So we call it a true lateral view. So we always see the fluoroscope using the horizontal view like this, and the true lateral view like this. So for femoral shaft center and the femoral head center come in the same line. It is quite important, a very useful view, not only the femoral head fracture, but also trochanteric fracture, like intermedullary nail and DHS in the both. This is the complete marking. But before the operation, if we do the marking like this, so we can do the operation through the very small skin, normally 2 or 3 millimeter. Without the marking, sometimes we can extend the wound to find the best place to insert the implant. Okay, so why it is important to make the skin incision on the true lateral view? If you make the skin incision just lateral to the femoral bone, so the skin incision come like this. So separate the skin and reach to the femoral bone here. But actually, screw should be inserted like this. So to insert the screw or guide pin from here, the muscle should be retracted posteriorly. So sometimes it is very difficult to retract. So instead of cut here, so if we cut here and open the skin here and separate the muscle here, it is easy to access from here to the femoral head center. So it is a reason to make the skin line on the true lateral view. And then insert the guide wire at a defined angle. This DRSC have the 135 degrees. So, but plus minus 5 degrees is acceptable due to the round shape of the side plate. So it is no worry to some minor alignment divergence. So insert a proper angle of this guide pin. I also devise this type of the guide wire guide. So put on the two nail here and here. Then this angle come 135 degrees. This is the same angle between the side plate and the screw. And sometimes this the pin head can be kicked by the hard bone of the femur. So this angulation, this angle, sometimes too steep due to the some kick by the screw head, guide wire head. To prevent this of the kicking of the guide wire head on the lateral side of bone, to this contact point is here, not here. This is very useful to insert the guide wire at the angle we desired. Okay, do you understand? Okay, I'm sorry. I have no time to explain. It is a time limit. Okay.
Yes, Professor.
Okay, tomorrow I will continue my explanation. Of course, yes. This is this is not only specialized for the DSCS. This technique can use universally for other type of components, such like the CHS and the cannulated hip screw. So maybe this technique is very beneficial all type of hip fracture. Okay. Okay,
yes, Professor, yes.
Okay,
very interesting.
I will explain my explanation of how to insert the DRSC screw. Maybe in the Monday, you still have the one set of DRSC screw. If you have a chance, please use it. Please try it. It's very easy. If possible, I want to introduce this implant in your country. Maybe it's very brand new, because to have the side plate is very important to stabilize the fracture. I believe even for the femoral neck fracture, the side plate is very beneficial, because sometimes the varus deformity can occur after the just simple screwing or pinning. Okay.
Yes. Okay. Thank you.
Thank you. It's okay.
Thank you.